Hello, dear friends. This is Adrian Baranchak from Queen's University in Kingston, Ontario, Canada, and I'm very pleased to be able to talk about Bayes syndrome and everything that a clinician should know for the Latin American Heart Rhythm Society. I have no conflict of interest, so the CACT initiative is supporting the presentations about Bayes syndrome. And before I start, I would like to dedicate this presentation to one of the ECG masters of the world, Professor Antoni Bayes de Luna from Catalonia. And I've been blessed to have the opportunity to write this book with him, which was released a couple of years ago. Antoni continues to work hard, and it is a real pleasure to share some thoughts about the syndrome that he has described with all of you. So why Bayes deserves to be recognized with a syndrome that has his name? Because he has basically described every aspect of this condition, from the pattern ECG of advanced intra-atrial block to the association with supraventricular arrhythmias, mostly atrial fibrillation and atypical atrial flutter. And this graphic that you see here is the one that we used to illustrate the first paper that recognized and proposed the eponym of Bayes syndrome, and it was done in the journal Archives of Mexican Cardiology because of the deep relation and friendship that this young Bayes de Luna had with Ignacio Chavez, who is, as you know, one of the most relevant electrocardiologists in Latin America. And since then, several papers have been published using the eponym, and the eponym has been accepted by the scientific community. So in the next 15 minutes, I will try to specifically talk about the relationship of intra-atrial block with supraventricular arrhythmias. And when I talk about advanced intra-atrial block, I want you to direct your eyes to the magnification of the inferior leads, the P wave in the inferior leads, with the first positive component indicating the depolarization of the right atrium, followed by a deep negative component, which is the depolarization of the left atrium in the backward direction. This happens through the musculature of the coronary sinus and the foramen ovalis, producing an intra-atrial dysynchrony, which predisposes to atrial arrhythmias. And this has been successfully published in Circulation 3 years ago on the association of this well-known pattern with the development of atrial fibrillation, and as I will show you later, with stroke and even mortality. But doing a brief review of only some of the contributions of Bayes de Luna to this topic is to show you that all the surface recordings were also evaluated by these basic intracardiac recordings that showed that the activation proposed of a first depolarization in the normal direction of the right atrium was followed by a retrograde activation of the left atrium, and intracardiacs have confirmed that. And Dr. Bayes de Luna went even a step farther, proposing that these patients that have not developed atrial fibrillation yet may benefit from antiarrhythmic medication in order to prevent atrial fibrillation. 10 years after the first descriptions, his son Tony Bayes Geniz, an incredible smart cardiovascular researcher, also brought some of his expertise to put these papers on the connection between the ECG pattern and the development of atrial fibrillation. Another groups also joined these ideas, and one of the most remarkable ones was the US group commanded by Dr. Spodek, which used a slightly different definition, however, did important contributions in the association between advanced intra-atrial block and atrial fibrillation, and maybe more importantly, adding up the concept that intra-atrial block could help in the prognosis and or diagnosis of people at higher risk of presenting with stroke. There's a lot to do in this field, and you will see it by the end of my presentation. But something that struck me when I came to be part of this team is that one may perceive competitors as people that you don't need or you don't want to work with. However, in the spirit of Professor Bayes, it was an integration. So in this consensus paper about intra-atrial block, he has invited Dr. Spodek to be the senior author of this paper and to reach consensus on some of the discrepancies. And as a result of that, the classification of intra-atrial block has two streams. One that I embrace the most is classifying it in partial intra-atrial block when your P-wave duration is longer than 120 milliseconds. For the clinician, just 3 little squares of the surface ECG. And in advanced intra-atrial block, where the P-wave is longer than 120 milliseconds, but you have this specific positive, negative morphology in the inferior leads. To do some sort of analogy to AV blocks, which we are all more familiarized, this consensus also proposed to call it first degree, second, and third degree. First degree is partial intra-atrial block, while third degree is advanced intra-atrial block. The second degree refers to intermittent intra-atrial block, also known as intra-atrial aberrancy. Something that our group insisted is that if the physiology of the intra-atrial block is a delay or a block of conduction due to progressive fibrosis of the atrium, that can be tracked in subsequent ECGs. And you see how in only 4 years, the P-wave is gaining duration, and in only 2 more years, the negative component develops. And that can be correlated with the areas of fibrosis in the intracardiacs and with the development of supraventricular arrhythmias. And of course, modern EP, this is already 8 years old, have made major contributions to the understanding of the fibrotic aspect of the intra-atrial pathways. And that can be clearly reassessed using cardiac MRI or less invasive, less costly studies like left atrial strain. This is a normal ECG with normal strain, and look at the deformation of the strain when you have intra-atrial block, clearly indicating that the electrical component also may lead to not only to arrhythmias but also to deformation of the left atrium and alterations of its function as a conduit. And I would like to show you that intra-atrial block, that for ages was considered as a manifestation of left atrial dilation, it can occur in patients with different diseases, even in patients with normal structural left atrium as a purely dromotropic phenomenon. In this paper, this group of Latin American investigators put together a series of patients with advanced Chagas who have a defibrillator, and this intra-atrial block pattern helped predicting atrial fibrillation. And then this brought the concept that the stroke, the high rate of stroke associated with Chagas, may not only be due to the apical aneurysm and a clot in the tip of the heart, but also with a higher incidence of atrial fibrillation due to the presence of atrial fibrosis. And in a different population, for example, in the one that has been cardioverted pharmacologically, when you go back to sinus, the presence of intra-atrial block clearly predicts recurrence of atrial fibrillation. And this has not been able to be proved in a much more heterogeneous population as the one that we evaluate after CABG. In this case, mostly likely because atrial fibrillation post-CABG may recognize triggers that may be more important than purely the anatomical substrate. In patients with advanced sleep apnea, which is other area of interest to me, the presence of intra-atrial block is highly significant. And more interestingly, if you treat patients with severe sleep apnea with CPAP, the size and duration of the P-wave depolarization can retrograde and return to normal values. So this is quite important in pathologies as sleep apnea and heart failure, where the reverse atrial remodeling may link to a reduction of atrial fibrillation. I want to show the next two studies for my colleagues from invasive EP, which are the body of LHRS. In the post-PVI population, again, in the post-ablation for atrial fibrillation population, finding this type of P-wave patterns were associated with a drastic recurrence of atrial fibrillation. And that is independent in a redo procedure of the number of pulmonary veins that are reconnected, indicating that intraatrial desynchrony is an alternative mechanism to the development of atrial fibrillation. And that's something that ablators should have into consideration while talking to patients about second procedures or third procedures. And the same thing happened after successful ablations of atrial flutter. Sometimes we're very happy because we took the cavatricuspidismus, the patient will never have atrial flutter again. However, within the first year or two, the patient returns with atrial fibrillation. Well, that is particularly true if when you go back to sinus, you find advanced intra-atrial block. That is a strong predictor of atrial fibrillation in the first 2 years. And the same thing happens in patients with advanced heart failure with the presence of intra-atrial block. These patients are clearly at higher risk to develop atrial fibrillation in the first few years after implant. And this has been reconfirmed by a second group in Spain with a very large number of patients. Enough to say that in the Spaniard group, the presence of intra-atrial block in patients with advanced heart failure also predicted stroke. And when you take it to the general population, and this is 15,000 people from the ARIC study, the incidence of advanced intra-atrial block was 2.27, and it clearly identified patients at higher risk to develop atrial fibrillation, 3 times more than patients with normal P-waves. And this group, commanded by my colleague, Dr. Martinez-Ayes, also demonstrated the presence in the very old population and the predicted value of finding intra-atrial block. And we did extensive studies in different patients with different manifestations of coronary and peripheral vascular disease, and advanced intra-atrial block predicts atrial fibrillation in the first year, and it supports all type of multivariate analysis that you want to do. And I would like to start finishing my presentation by introducing a new concept that I had the pleasure to work with a group of very talented researchers, which is called atrial failure. As we talk about ventricular failure, and we refer specifically to a disease of the ventricles, this concept refers to any atrial dysfunction, anatomical, mechanical, electrical, rheological, including blood homeostasis, causing an impaired heart performance, linking to symptoms and deterioration of your quality or quantity of life, in the absence of structural valvular disease or ventricular abnormalities. And I have the pleasure to share these thoughts and to publish it recently in JACC, along with these 2 young fellows that are very promising. Pay attention to these names because I think that we will hear more about them in the future. And I refer to Professor Bayes de Luna and Professor Eugene Branwell. And in this paper, we tried to divide the causes of atrial failure, the mechanisms involved in it, and the clinical manifestations. And as you can see, electrical desynchrony, which I've been talking today about the Bayes syndrome, the failure of the pumping capacity, the failure of the reservoir function, and the deterioration of the conduit function all lead to atrial failure. And with atrial fibrillation is part of the clinical manifestation, the activation of procoagulation cascades and the deterioration of the left ventricular performance also occur, leading also to pulmonary hypertension. And this is why the manifestations of atrial failure are around the major cardiovascular syndromes: heart failure, ischemia, stroke, syncope, shortness of breath, palpitations, angina. It's very important to distinguish these terminologies in order to be able to advance this concept. And again, the alterations of the electrical dynamics of both atria have been extensively published, and I want you to put this pattern in your hard drives so you can recognize it in your next clinical encounters. As I said, the presence of partial or advanced intra-atrial block help us predict an atrial fibrillation in patients with carotid and coronary artery disease. This group from the Jimenez-Diaz Foundation also identified this in patients with pacemakers. So they use a surrogate of atrial fibrillation, which are atrial heart rate episodes, and intra-atrial block was able to predict them. This is an interesting meta-analysis from the IHIS group commanded by Dr. Tseng Hong Kong, showing in different populations the value of advanced intra-atrial block predicting atrial fibrillation. In patients now with ST segment elevation, a beautiful paper from Turkey with Göksel Senior, the coordinator of the International Society of Electrocardiology Young Community, identifying again intra-atrial block as a predictor of atrial fibrillation. And now, almost closing, the question that arises is, should we anticoagulate patients at high risk to develop atrial fibrillation, but when we have not documented atrial fibrillation yet? This is an open question, and this talk does not pretend to say that yes, that we should direct our efforts to determine whether these ECG predictors are enough to consider this. The answer to this question would only come up from a randomized control trial. So I want you to read this recently published paper in Preface, where we did the Bayes registry, which was intended as a 3-year follow-up inclusion of 650 patients older than 70 years old with some degree of structural cardiomyopathy, and divided into patients with normal, partial intra-atrial block and advanced intra-atrial block. We stop it at 18 months because the patients with advanced intra-atrial block have a significant higher incidence of atrial fibrillation, a significant higher incidence of stroke, and a significant higher incidence of atrial fibrillation or stroke, indicating that we are ready to prepare a prospective randomized control trial of using some sort of NOAC versus either aspirin or placebo in patients with no documented atrial fibrillation, but with this patent, ECG patent, in the presence of some degree of structural heart disease. So I would like to finish with a little bit of self-propaganda here, advertising this book that we put together with a large amount of colleagues that I'm sure are listening to this presentation. And I would like to highlight the preface that Dr. Brunwald wrote for this book. He said, "This book will surely stimulate interest in what has been a largely neglected corner of cardiology, and as a consequence, outstanding work of Professor Bayes, Baranchak, and collaborators have contributed to this book, Intra-Atrial Block, not to be no longer a stepchild." I am very proud to present this book to all of you and to contribute to keep advancing the discoveries of Professor Bayes de Luna. So to finish my presentation, intra-atrial block is a well-defined conduction disorder. Most of knowledge has been advanced by Professor Bayes de Luna. The association between intra-atrial block and supraventricular arrhythmias, most importantly atrial fibrillation, is now known as Bayes syndrome. Advanced intra-atrial block predicts atrial fibrillation after electrical cardioversion, atrial fibrillation ablation, atrial flutter ablation, patients with hypertension in the normal population, in patients with Chagas disease. The more the different populations we study, the more we find this simple electrocardiographic marker predicts atrial fibrillation. The Bayes registry has confirmed that. So the remaining question, and I hope to be able to answer this question in a few years from now in another LHRS meeting, is should we consider anticoagulation in this group? So I am saying, be calm. Let's wait for the results of the randomized control trials. We are directing efforts in this direction. So I want to thank my colleagues from LHRS for this lovely invitation. Thank you.